websites up there. The first one, the PPCL one, is for our basic research, actually basic and intervention research, if you want to download a paper or at least get a reference to it. The second one is for the Center for Parents and Children, which I'll tell you about as we go on today, but it's more for resources. Now, I must say, this is actually the second talk I've given since the passing of the developer of the Family CheckUp, Tom DeShawn, and I owe him more than a lot, to say the least. But he is the person who really developed this. I helped Tom adapt it in early childhood, but we miss him very much and very dearly. Other people who were involved in this research include Francis Gardner from the UK, and Gil back in Pittsburgh, and Mel Wilson, my collaborator down in UV. I'll bring up Tom again as we move ahead. If those of you, he passed away in early June after battling some repercussions of a stroke the previous year, so he's been on our thoughts a lot lately. Lots of people to thank. Literally hundreds of people have participated. Just the research team, not to mention our families that we're very proud of. Most of the research you're going to hear about today has been done in women, infant, children nutritional supplements programs in the Pittsburgh area, but also in Oregon and outside of Charlottesville, Virginia, and then NIH has been very helpful for us the last 30 years in putting this forward. Just to give you an overview of this talk today, I am going to very briefly review, this is the one basic research. I understand some of you are taking a class with Lisa, and so you have to absorb research. So I'm going to give you 3 research slides before we're getting into the intervention. And this is based on 20 years of data collected. And I must say, it is hard to summarize 20 years of research in 3 slides, just so you know that over time. And then I'm going to spend most of the talk providing an overview to introduce you what the Family CheckUp is and how it's been applied to toddlers in the WIC clinics across the United States. And then the third part is discuss our recent forays outside of WIC, and that Pamela will also discuss one special one in pediatrics later. So I'm putting a bunch of risk factors on the board right now. I was asked back in the 2000s to do a review for the Institute of Justice and the question was, is there anything to this early childhood piece? Can you actually predict antisocial behavior before the age of 3? Anything. Are there any variables? And again, this goes back to our impetus. And all the variables on the board have been shown in prospective research. That means not looking back, but looking forward to predict antisocial behavior after age 10, beginning before age 3. And some of these don't surprise you at all. I'm sure parenting maltreatment, of course, is up there. Prenatal exposure to tobacco and alcohol, by the way, has the largest effect size of anything on that board. Maternal depression, hassles. And I put this up there because if you believe in cumulative risk, we always go for parenting. But there might be other ways in the system here. If you can, for instance, eliminate poverty, would get rid of about 5 or 6 of them on the board right now. But if you're going to be in that context, you're going to be facing a lot of those over time. So this is a challenging mission is what it's meant to be. But the good news is, if we could change some of these variables in early childhood, kids might have a better chance of succeeding. So as an example, what better way than to use my own research? Again, this sample was recruited back in 89 and 90, well actually recruited in 91, 92. They were born in 89, 90. 310 boys. We focused on boys back then because they had higher rates of problem behavior, and we had a smaller sample of girls, but weren't able to follow them. You can see the low income. They were living in the Pittsburgh area. They were not a young teen sample. We also required them to have a sibling at home. That is, we wanted to increase risk a little more from research that had been done by Shep Kellum here in Baltimore, actually many years ago, showing that it was the size of the family that really produced a risk. At the very bottom, it says 36% criminality. Those are the percentage of parents that told us they had been convicted of a felony in the sample. Interestingly, when their children, the kids I'm going to talk about, by the time they reached 17, 38% of them had a petition against them in court. So in terms of intergenerational continuity, it was very high, or if you're a family or a genetic person, you might think, oh, this is, yeah, not good. This was until about 5 years ago, my life, following these families up, slide number 2 on this, and you can see we saw them up to age 23. We're trying to find out how their cardiovascular and cardiometabolic disease situation is now, trying to look at them at age 29 and 30. But we were able to continue with 83% of them at age 22, which we think is pretty good, given cell phones go off every month on bills and things like that. So we have good retention on them, and there's no reason to suspect the kids that were with us at 23 were different than the ones that dropped out of the study over time. So here is the slide that kind of summarizes those 20 years of data collection. 1, observed parenting quality, maternal depression, and other family stressors before age 3 were the best predictors of persistent antisocial behavior from ages 2 to 17. Emphasis on the 17, right? They're still predicting these things, even after accounting for later depression of moms and later parenting practices. Beginning at ages 2 to 3, child issues with emotion regulation, oppositional and aggressive behavior were also consistent predictors of adolescent and young adult antisocial behavior. Note, this would not necessarily be the case if these were middle-class families, because of the resources of the schools, daycare, pro-social, extracurricular activities, physical space, all those things that get in the way of low-income children's development. In predicting adolescent violent behavior, you would think public policy people would be interested in preventing violent behavior. This was best predicted by income, minority status, being black in Pittsburgh, parenting, and child emotion regulation, all measured before age 3. Okay? The results suggest that targeting these behaviors, especially in the last column here, in early childhood, that are quite malleable, by the way, might be the way to go, right? So that's kind of the backdrop for all this. Hence, there's this chasm between basic and applied research. Despite having this evidence, and we're not the only research team, the University of Minnesota and the Dunedin Project have all, in New Zealand, have all found very similar ideas in this, although they don't go quite as far back with as many males as we do. Despite this predictability of several risk factors, the rates of successful clinical referrals in our basic research are poor. The example I gave being the most telling, 3 out of 148, right? I don't have to go over that again. The question is, how do we bridge this gap by not just identifying, but motivating families with high-risk children, right? It's one thing to know something, it's the other to say, how do you convince a family that your child may not be on a great path here to success? This is our best weapon. This is how I convinced Tom to say, you know, adolescence is rough, but wait till you see the terrible twos, right? And, you know, this, we think about this, these pictures up here, but think about it. In the second year, you have these wheels that work all of a sudden. You don't understand gravity, you don't understand electricity, you don't know what it means to hit somebody else and how they feel or anticipate things. And this causes parents to act, right? Sometimes more harshly, and kids to use that word no, and parents to use the word no. So it is a battle in the sense of, and it's a right time where parents actually want to talk about these things. One thing we learned in our basic research that we had a lot of parents who were pretty desperate during this time over here. Let me then introduce this family checkup and how we got to early childhood. It was suggested that this was an intervention tailored to answer the call, providing a means for engaging high-risk families during times of developmental transition. So I'll talk about Tom's work in a second, but a lot of it had to deal with adolescence, another time of turbulence in parents and kids. And the idea being this helps fill this chasm between our knowledge of risk factors and applying this knowledge in settings and motivating families to do something about it. So we always have to begin with the light bulb joke when discussing this. This is required reading if you're becoming a therapist, by the way. How many therapists does it take to change a light bulb? The traditional answer is 1, but the light bulb has to want to change, right? Everybody should know that if you don't. I'm changing the answer to 1, but you need to motivate the light bulb to change, right? Desire. A lot of our families did not do well at school. They haven't done that well in life. People give up on them a lot. And they're used to that too. How are we going to convince them that they can do something about it? Accessibility, the example I gave, that 3 out of 148, that sticks in my craw every day. Coming in at night with 2 kids, oh yeah, that sounds like a great time. And no babysitting, we'll get a lot of work done. Sure, I won't do that. Versus making it easy for families to do it at their home or wherever they prefer. Some of our families don't want to do things at their home. We're going to come to them. So we're going to become more user-friendly to make it, and then not giving up on them. I mentioned about the motivation piece. Families are used to people giving up on them, not coming through. They're not doing well. How do we hang in there with them over time? So that's my change to the light bulb joke. Another semi-joke here. You can see what is the meaning of getting help? And we think of traditional therapists, maybe models you're being trained in right now. Here, Lassie is told to get help, and she has a misinterpretation of this and decides to watch out for herself, right? How many people here know about motivational interviewing? Yes, it's really spread the word, right? So this is a different tact than traditional therapists have been trained in. We're going to give direct feedback on how you're doing. Much like an insurance salesman scares the hell out of you to get, we're trying to do this with your child's future over time. And we're going to put it on you to make that decision. We're going to give you advice. That's not in the Therapist 101 handbook, right? Because we're an expert, we feel qualified to do that. And we're also going to give you lots and lots of options, including you take the ball, I'm out of here if you like. But these are the data I have. We're going to emphasize empathy, because we know that it's important in joining. We're going to emphasize self-efficacy, because eventually, whether I'm going to your IEP meeting or not, you're going to have to do this on your own. We could role play this. I could be there for the first one if you want me there. I'm going to help you through this, and I'm going to be there, but eventually I want you on your own feet. So our intervention's pretty brief, as you'll see. And of course, establish this collaborative relationship. Emphasis on collaborative, not top-down. So if you don't want to work on an issue, even though the data are there, it's your call. It's up to you. So parents are really feeling in control in this over time. So let me tell you about the evolution of this, because I constantly get credited with developing the Family CheckUp. I did not develop the Family CheckUp. Actually, Tom DeShawn developed it based on watching Bill Miller's work. If you don't know Bill Miller's work, who invented motivational interviewing, he was working with adult alcoholics in New Mexico and discovered that with 3 one-hour sessions of motivational interviewing, he could get the same treatment effects, long-term treatment effects with alcoholics as 30 days of inpatient stay, which is quite remarkable, and he sustained that over time. Tom saw this, and I think this was Tom's genius. He saw this and said, what if I transfer that dissonance, which is what MI does, it creates dissonance between what you're doing now and where you'd like to be. He took that and said, get parents who care, their lives may not be going so well, but the one thing they usually care about are their kids. Dissonance between what they want for their kids right now, and these were kids, adolescents now, who were struggling, staying in high school, and where they want them to be in 4 or 5 years, which is really close. They were 13, 12-year-old, 14-year-olds, those kinds of things. And Tom said, what if we could apply that dissonance to families? Give them direct feedback about how their adolescent is doing over time. And that was the idea. When I met Tom in the late 90s, I said, I think I have another age period for you. Would you be up for working on this? And we started a pilot study in Pittsburgh, and then this larger scale study that I'm going to tell you about with 700 families in Oregon, where Tom was, and UVA, where Mel Wilson was over time. Kate Kavanaugh was a big piece of this in the 90s in his adolescent project, and Beth Stormshack along the way, too. All right, so what are the principles of the Family CheckUp? How is it the same and different from other interventions? And remember, it kind of spreads the age period. So we're now doing this at birth hospitals with infants, but it was originally done with adolescents, early middle schoolers, 6th, 7th, and 8th graders. So it is applicable across, and I know Beth Stormshack has just published a paper with 5- and 6-year-olds, so it kind of spans a life course in childhood and adolescence. It is based on an empirically based model of child and adolescent problem behavior, meaning we can use our developmental data to inform this over time. We're going to focus on developmentally critical issues for parents and kids during that time. Secondly, it's family-centered, much like structural family therapy and other models. We're going to put the parents in charge. How many people here have seen a family where the 2-year-old is running the show? Yeah, we see a lot of those too. So we're going to put parents back in charge, and we don't take it for granted, by the way, over time. So, and parents may not feel comfortable in that role, and that's where you get the resistance, and the case plays out. It's assessment driven, so this is a little bit different, although a lot of interventions do informal assessments. Everything we do is based on that assessment. It is going to drive what comes next and where we're going to focus our attention. Notice it will be filtered by the parent's motivation to work on that issue. Example, parents high on maternal depression, the marriage is going downhill, and the child is a problem. But they don't want to work on the marriage or the depression. Let's just work on the child. We'll respect that and let them know the consequences of that. But we're not going there with the marriage or the depression if they don't want to. We're not yet, at least, over time, not until they're up for it. The Family CheckUp tries to target social interactions with parents and peers to the extent that the parents of adolescents, we might want to control the peer environment. We're not bringing the peers into the room. In fact, in a lot of cases, we're not bringing the adolescents or early young children into the room. A lot of this is work just with the parent in terms of logistically. It addresses the client motivation to change as a core component. You don't want to go there, we're not going there, it's up to you. I'm just here to share this information with you, and if you want to do follow-up when and where, I am there. I am in, but it's your call. Very important to give parents control. And then the last piece is utilizing a health maintenance model. We believe this is more like treating diabetes or dentistry than surgery. We don't think we can come in there and permanently change everything. We like to be able to do that, but we know families have ups and downs, partners change, children move around. We don't assume that's going to happen. So we think of this more like a well checkup at a pediatrician's office, where you come in regularly for these things. And some years, you just need that checkup. Other years, you need follow-up services. And we'll be there for that. So we're trying to build these into healthcare models, other models that serve families in need. So in terms of what we did in this is now an NIH research study. So I'll bore you with a few details of this and show you some findings. And then I'll show you some video clips of what parents' experiences were like in this. So we did an initial screen at WIC, and we did this screen, this is important, we did a screen because we knew from our other research that a lot of families in WIC, their kids do quite well. We don't need to be seeing. So we used our basic research to inform this screen, that is things like maternal depression, infant irritability, parenting stress, maternal depression, those kinds of things. And from that, we selected about 50% of families who were eligible at that time. I think there were 1,600 and 731 ended up joining us. We had assessments at age 2. We began this at age 2, which is kind of interesting, kind of the heart of the terrible twos. The first part of the family checkup involves an initial get-to-know-you visit, which I'll explain and show you a little clip of over time. During this time, we're trying to use all our, I'm going to call them weapons, all our repertoire of joining that you would do in a first interview, where we're finding out, tell me about your child. What are your aspirations do you have? What are your struggles with them? I need to get to know. Next week, I'm going to come here and do this formal assessment. Before that happens, I want to know how I should read that data from your perspective over time. What's really important to you? So there's some establishment of trust over time. When we did this in rural Virginia, where the commute could be 45 minutes to an hour and a half, sometimes it lasted more than 30 minutes because of that drive. But typically, these can be 30 or 40 minutes. To save time, we're actually combining this with a much shorter assessment these days. So instead of 3 sessions, it's 2 sessions. Here's the part that I regained my faith in humanity after this. Remember the 3 out of 148, right? All right, our first entree, this is with 120 families in Pittsburgh. We got 92% of families to have at least 2 home visits with us doing the family checkup. 56 of 61 families. When we went large across the country at 3 sites, it went down to 75%. But in that study, we actually had repeated family checkups at ages 2, 3, 4, and 5. By age 5, over 90% of families randomly assigned to this intervention had at least one family checkup, meaning they had a get to know you, assessment, and feedback sessions over time. So we were really pleased with that. We've now done this in pediatrics, and it's actually higher in our adolescent sample there. It was 93% over time, 86%. Another study, I think in the study Pam was talking about, it's in the 70s over time. We're going back and forth with that. At the very end of getting this feedback, where you hear everything about your life crystallized, and it's like having a mirror of your life put this close to you. It's very hard to ignore these data. Very hard, because it's everything you've told us about your family, all these measures you've taken, video observations that we show back to you, things you're doing really well already, right? We ask, look, if you were going to change something for your child's life in the next year, what might those be? And we ask them what you would think about that. And this is a really hard part for families. We take that, it's got to be their words. We give them a copy, we take a copy. Some families put it on their fridge over time. What happens after that is up to the families. About 60% have follow-up sessions with us where they might get parenting skills, and we use our everyday parenting curriculum, which looks a lot like PCIT or an individualized version of Incredible Years. It's based on the Jerry Patterson social learning model that Tom helped build as well when he was at Oregon Social Learning Center, and, or Marion Forgash's work as well. Average number of sessions. In our first pilot study, small, we had 2.95 sessions per year with our families. This means the get to know you and feedback were 2 of those sessions. On the average, families had 1 more session. We were earning and learning at that time how to do it remotely with Tom. We got a little better by the multi-site study. There, the average number of sessions was closer to 4 per year, meaning on the whole, families had a feedback and 2 sessions after that. There were some families that had 9 or 10 sessions, and some families that just had the feedback over time. So this is kind of a map of what it looks like. And just to be clear, because it was a research study, the home assessment came first in this, only because of research, and we didn't want to prime the families who were randomly getting the family checkup by having this contact. But in the real world, these 2 visits are now 1. Instead of our 2.5-hour assessment, this is an hour, and this is about 20 minutes over time. And then interventionists digest all these data, which is scored through a system, and it is complicated if you don't have that scoring protocol. And then we deliver the feedback a week or 2 later. And then, that's the interesting part, and then families decide what they want to do. Some do nothing. Some want to have follow-up family management treatment, but you could slide PCIT into this, or other interventions you're currently using. It's kind of a primer of kind of where focusing things are over time. All right, I want to show you, this is an interesting example. This is a mom who was enrolled in our research study, and this is the get to know you version, and this is Ann Gill talking with her. The audio isn't that good, but we transcribed it, so hopefully you can follow the speech down there. And this is a mom trying to figure out what she wants for her child and how hard it is for her. pretty powerful. You know, as a mom who doesn't have that model, she knows what she's doing. It's not quite sitting right, but she doesn't have an alternative over time. And it's really helpful to get that out there. And this was in the first meeting with the mom over time. So, you know, a lot of people look at this like, this sounds really distant or something like that, but it turns into something very personal, obviously, as you can see over time. This is what the feedback looks like. People in the back, I bet you need 20/10 vision to see this. But essentially, this is a chart of, and there are different versions of this depending on the age group. We've actually made it a lot simpler over time. But what you see here are a list of different attributes, starting with temperament, child behavior problems, language development, quality of relationship. Then we get into parent-reported well-being, depression, social support. Everything on this chart predicts later problem behavior. So these were chosen based on our basic data of not our own research, but a lot of people's in the field. And then we have, in the case of our new version, it's like 15, 20 minutes. Back here we had 50 minutes of observational data to choose from. And we're going to try to emphasize things that are really going well. And then finally, we have parent report of their resources. What's going on in the neighborhood? Do you feel safe walking outside? Those kinds of things over time. So we're trying to create a big picture. Now, if the interventionist, who we call family coaches, reads this like a laundry list, it goes flat. There has to be a narrative. There has to be a story that it compels parents that they can identify with. So in this one, the green means things are going really well, and we'll always start with strengths, and the red means needs attention. They've passed some kind of clinical cutoff in most cases for this. In this case, what really stands out here, this is the observations of parenting. In this case, mom was a rock star in terms of working with her kid. She could set limits, she could anticipate everything she saw with the child. She was on top of things. The only problem is that she is depressed. She's above the 20 point on a CSD score in this case. And she sees her child as being in the clinical range on the child behavior checklist. That means if there are 100 kids here, your kid would be one of the top 2 in terms of being disruptive. Not something you want to hear about your child, right? So how we would frame this is, look, you showed us these skills, and we would show her video clips of this over and over again. This was amazing. Did you see the way Johnny lit up, the way when you smiled at him, and how he was looking for guidance and you were there? I mean, really smother the parent praise, which she probably isn't getting anywhere else. And they say, what's getting in the way? You know, you said you don't want to get up in the morning, you're feeling down, you don't want to do anything with your life. You know, this is consistent with someone who's clinically depressed. Do you know what that means for your child? So instead of saying you need therapy, it's all about pulling the attachment strings to get parents to kind of engage more. And I saw your child. No wonder you're feeling depressed. This child is really hard to manage. You know, so we're throwing kids right under the bus. We don't care. We don't care because we're trying to capitalize on the parenting strengths here over time. I mean, that gives you a sense of how this would become much more story-like than saying, oh, on this you scored this and this. It would feel very plastic and contrived. Here's what it's like to hear this. This is a woman Anne did not see in Family CheckUp, another of our interventionists at Tracy, but she's talking, her child is now age 9. This mom was severely depressed, homeless at times during the periods of study, and this is kind of her story. About her experience with it.
What was that like as a parent to be receiving feedback about how your child is doing, how you're doing, and how about your parenting?
I think it was nice. I love the feedback because when you actually sit down and look at the progress of over the years and you know the different aspects that you're trying to set and you see that you're accomplishing them and your child is, it's awesome. You're like, wow, this is working.
Yeah.
You see what I'm saying? Like, I know it's working for me and my family because the changes that they're making, that's it.
Yeah.
Change.
Yeah. And you can see progress over time.
Oh yeah, their behavior, you know, the way they talk. You know, they talk proper. You know, they're yes ma'am, no ma'am. Very respectful.
There's one more of a woman, one of our Oregon families, also talking about her experience getting feedback per se, what that's like, which isn't necessarily pleasant at the time.
Like I said, it was kind of hard sometimes because, you know, but the way it was done was very positive. So the feedback sheets had, you know, here's normal, here's concerns, here's things that are going well. And we always went through over the positive things. It's really working out. And then there'd be things, okay, these are the areas that are concerned on a scale of everybody. These are, you know, so a lot of the times they were depression. A lot of the times they were, you know, self-esteem for him, especially going from, you know, grade school to middle school kind of thing. All kids are like that. And then things we could do about those. The tools that we had in the positive, how we could use them with the negative. Where in the negative did I feel, or did we feel, that, not negative, but in the things that needed help, you know, what ones were the most important in my priorities to work on, and the kind of steps that we could work towards those, and always trying to keep those in mind, like doing the goals. The goals, the yearly goals were, you know, after looking at those and then putting those down and then working towards them. I was looking at one of them, and it was working on sleeping by himself and working on more independence. And one was more chores around the house.
Right. So this is what the goal sheet looks like, modern day version of it. We try, some families write 7 or 8 over time, and others have a hard time. And it's very important, again, that these are their words. And then they decide, how do you want to address these goals? What do you want to do? You want to do this by yourself? We're here, and we can nominate this. We used to, because we were so into MI and it had to come from the parents so much, parents used to say, well, I want to work on parenting. How about you call me once every month? And we used to say, okay, I guess so. And now we're like, well, no, we have the knowledge and we don't hide. Well, actually, if you want to get a handle on this, it might be best to have 2 meetings the next 2 or 3 weeks. And we find parents make a lot of progress if they can get started on something concrete. So this is the research study again, going back to it, following up these families. They're now, we just finished our 8-16 assessment. The intervention was continued every year, 2 to 5, and then 7 to 10 annually over time. So we got to really test out this health maintenance model. And now we're looking at outcomes all the way up to age 16, where we're still getting 81% of our families across these 3 sites. Here are some again, this is a randomized controlled trial, and in early childhood we got improvements on parenting, maternal depression, inhibitory control. So you think about those 3 outcomes. Remember, those were the 3 areas that predicted later violent behavior in adolescence, at least among our males. We're getting intervention effects on all 3 of those. Disruptive behavior, parent-child relationship quality. We think we're giving parents more skills, which leads to better attachment quality too. And we use Bob Pianta's measure to look at this over time. Social support satisfaction, lower BMI. We didn't expect that. So we're seeing all these collateral effects. Lower levels of parental neglect when we do our observations by folks who are blind to the intervention. Improvements in child behavior seem to be mediated by, guess what, improving parenting and or maternal depression during ages 2 to 3. No differences for boys or girls, despite our basic research being done on boys. So we were, thank goodness, this seems to be working for girls. Also no differences among our Latino versus our African American sample in terms of effects. Even though in Pittsburgh, at least, our African American parents and families live in much worse conditions over time. This continues when we jump to school age, less oppositional behavior according to teachers at school who have nothing to do with the study over time. Less conflict with teachers, less internalizing problems, better academic achievement in our kids if we change parenting in early childhood. So this is an indirect effect. And we were actually on a hiatus from funding for a year or 2. So we got to see, not voluntarily, mind you, but we got to see when we came back to the intervention, did parents in the intervention group, were they more active in the getting services and needs of their families met? And they were. So we had not just taught them to comply with us, but actually some skills in getting services for their kids. Faster rate of inhibitory control growth, reductions in peer rejection according to teachers. So our kids are getting rejected less at school. They're having lower trajectories of conduct problems all the way through age 14. And we're seeing some findings now on substance use at 16. Again, most of these effects are accounted for by changing early parenting and/or maternal depression by age 3 over time. So again, I'm preaching to the choir, but here's some evidence if you need to take this to your local agencies for proof of why this is important. So I wish the story ended there, but it doesn't. An issue for our research and our own is kind of looking back and seeing, well, you know, I bet not everybody did well on the family checkup, right? So it's one thing to screen for those who are at risk for conduct problems. It's another to screen for who's going to respond to our intervention, right? So we're going to throw ourselves under the microscope here. Perhaps there are certain families that do better and not so better for those that are randomly assigned to this. And what we found was not necessarily pleasing, but informative. This is 5 groups of kids that are families that were formed a priori, not knowing their intervention status whatsoever, and looking at how they responded to the intervention over time, right? And what you see is that what you want to see, the D stands for the effect size. Larger numbers are better, and these are all in the right direction. And this is where, unfortunately, I'm throwing our intervention under the bus. There are 2 groups which represent the majority of those randomly assigned intervention that did not do well, right? These are all WIC families, low incomes, high single parenthood, otherwise low risk. D is -08. This is not good. We do not want to see this, but this is what happened. Another large group of 180 families, we could have flipped the coin. I mean, they would have spent their time better doing something else. The families that seemed to do the best were those where there was very high maternal depression and single parenthood, or high child behavior problems, very high number of kids, high neglect, high maternal depression. You can see effect sizes very large here. Anything close above 0.5 is quite good. 0.3 is even reasonable. This is kind of for the whole sample what we get in our research findings. But this one really unpacked it. So what we saw here, the other group that responded really well were those where there was previous indications of child maltreatment and extremely high mental health treatment in the parent and antisocial behavior. So what we're finding, even though this is a very brief intervention, it works much better for higher risk families. It's kind of the bottom line. A little bit of a surprise. So to summarize this, our basic findings, we think these early step project, and there was this pilot study too, to use this model-driven intervention that is based on developmental work could be very helpful. It helps fill this chasm between basic and applied research to help motivate families to work on what they want to work on. And what's interesting about our research too, those that did not engage with us, their kids did pretty well, by the way. They knew better than we did in terms of our initial screening. So these are families who typically do not use community mental health services, as evidenced by our 3 out of 148. We have good data on that. And then we're showing 2 to 12-year outcomes from both our pilot and multi-site study. It's clear that only a minority of the children screened on the basis of just risk for problem behavior seem to respond. So this enters our next version of this, which is screening. Will Pelham, Bill Pelham's son, by the way, if some of you might know of him, is the one who really put this research forth. He was a student of Tom's. That screening is really important. So we not only need to screen for risk of problem behavior, but what our response will be to our selective intervention or not over time. For some families with at-risk young children, the family checkup might be overkill or insufficient to affect change. We might need more lighter touch and less expensive universal programs such as Video Interaction Project, that you're going to be hearing about really soon, or the Durham or Family Connects Project, which I understand is going on, or will be going on very shortly in Baltimore, which is really also really cool. Paradoxically, despite its relative brevity, the family checkup might be more effective for higher risk families. History of maltreatment, mental health services, antisociality, and maternal depression. We need to include those in our screens, and we are. So we are now doing this. We thought WIC represented an example of a novel platform for implementing the family checkup, but mental health services are, they're not typically provided there. However, there are other platforms where parents have greater trust what we can capitalize on, and might be even more open. So we can even improve on those engagement rates is the idea. We're currently doing 2 NIH trials in pediatrics, which is a natural place. One is with adolescents, going back to Tom's original work, although he recruited families through schools. We're doing this with pediatrics, and we have about a 93% engagement rate in that study. These are kids and families coming in for well-child visits. That's all. They're not expecting intervention. We give them a 15-minute screen as a parent and child, and that's it. And then this other study that you're going to hear loads about in a few minutes, but this is with infants starting at birthing hospitals in New York City and Pittsburgh and combining Family CheckUp with video interaction project. That's all I'm going to say about it right now. The other thing that happened to me, which I'm very happy about, is that Pitt decided to give me a center a couple of years ago. And essentially, they have allowed us to have now hard money positions to engage families and interventions in the community. So we can actually go out there as representatives of Pitt and say, hey, would you like to use these interventions over time? Which is really cool of them making that investment, probably because they didn't want me to leave, but I'll look on the bright side of those things. With the center, we can train and supervise existing staff immediately or down the road using the Pitt staff. We've now trained folks in Head Start centers in Pittsburgh, and also we were recently funded to implement these family support centers, which are around. We hope to get even bigger. We're also working at Head Starts, and with Deborah Bogan, our colleague on our Smart Beginnings project, we are now working with opiate-addicted moms, and again, her babies are in the NICU right after birth over time, and that is its own story. Nancy can tell you more about working with those families later. Part of this new kind of version of our Family CheckUp is to screen not just for risk, but for response to treatment. So we're already asking about depression, but we're asking about mental health services and child maltreatment. And we're trying to build this in. So we're working with WIC, we're working with Early Child, with Early Head Start, and other centers to get them to put a screen in their existing system. Okay? So they can have accountability for how they're responding to, let's say, the Early Head Start program. And if we are lucky enough to add Family CheckUp to that, we'll have data down the road. If you're thinking with your research hat on, this is a different way of doing research. Instead of saying, hey, I got this great model, would you mind if I come in here? Why not partner from the ground floor with these agencies, right? Work with them, get them to use measures that make sense from your perspective, that are targets of your intervention, and collect that database. And then you're going to have families you can't see how they do over time versus ones that get your intervention. And that's what we're trying to do throughout the city with these different, Child Welfare, Department of Human Services, they actually in Pittsburgh have analytics, and every baby who's being born right now gets a score for risk of child maltreatment, and we're able to follow that over time. We're not intervening with those families, but we know which ones are higher risk, and then we can see which ones are better or worse at responding to our intervention. Last slide. As of about 2 weeks ago, we learned that Children's Hospital in Pittsburgh is also contributing to this amazing study where they want to make a difference at the population level. And they have put me and Dr. Bogan in charge of a birth cohort of 5,000 kids over the next few years, where parents are going to have the option, and option being a very important word here, of engaging in different interventions based on screens we give when babies are born and at 6-month intervals over time. So I'm in charge of the age 2 to 3 cohort over time, and the idea is these families will grow up. We're trying to increase school readiness and eventually graduation rates over time. And it's really important here, this is not an RCT trial. This is parents saying, look, based on your results, it looks like you're really good to go. However, if you want this texting program to help you in parenting, we can sign you up for it. If you want to do the Family CheckUp down the road, that's great too, or a video interaction project, based on how you score on the screen. Based on the strengths and challenges ratio, yes, we'll be offering this menu. I already said that. And then what's important here is that families can choose to do nothing here. So we're not coercing families in any way. We're just offering them, and we're using this research. So, this has been kind of the goal of the center to do 10 or 15 years down the road, and Now it looks like we're going to at least have this chance to do this experiment in the next coming year, which is intimidating to me, but quite exciting. Last slide. So resources provided by our center, we're quite enthused about the prospects for raising the bar in the local community for evidence-based work, not just for intervention, but for screening too, so we can locate and then finding interventions that really fit with them. Not everyone, in fact, not half of our at-risk children seem to respond to the family checkup. We have to deal with that. We have to find alternatives and can't pretend that it works for everyone over time, even though we like it some of the time. So we need to refine our family checkup to address such issues as trauma, family chaos, and abject poverty, but also using complementary approaches. So teaming with Video Interaction Project has been one foray. We're teaming with Early Head Start in another because of that relationship there. Lots of possible novel platforms to explore that have not traditionally been provided, but really open the door for preventive interventions in the future. I will stop there. Thank you very much.
We have time for questions.
Questions?
Yes?
Hi, I just have a question. What is the cost for the checkup program for family?
You mean for per year? How much does it cost?
Per year.
You can think about it. Usually the average provider is going to be someone with an MSW, by the way. No advertisement there. And and they probably, not immediately, but during the year can see about 50 to 60 cases. So you can kind of do the math. It comes out to about $500 or $600 per family per year. It is not as cheap as Video Interaction Project, by the way, but it's more, we can use people with BAs or BSs for that. But we do think it takes some sophistication to go through that feedback. Tom tried it with folks who had not even graduated college, and the results were somewhat mixed. Yes?
I'm from infants and toddlers, and so
Yes.
when you were talking about this, you said early Head Start. That 0 to 3, when we do initial assessments, and they're, of course, coming from a school system, and I'm mental health,
Yes.
there is a difference in
Much.
approach. So my thoughts are, when you're looking at RBI and routine-based interviewing, and you're looking at the worst part of the day, have you thought of doing a social, emotional, mental health RBI type of thing with understanding what some of these issues are?
Could you say a few more words about that, what that would
Well,
mean?
routine-based interviewing is when we're asking a parent and when we're doing initial assessment, what's your worst part of the day?
Yeah.
When you're dealing with a multidisciplinary team, they come from a different approach. As the mental health person, I'm coming from what makes it so difficult for you. So adding that component piece
Right.
to this, and I having not seen your family checkup, I don't know what it looks like.
Gotcha.
So
Yes.
that's where I'm at a loss
Yes.
there.
I would say during the initial interview, it's going to come out, the get to know you visit. You saw a little bit of that. I want to do well by my child. I don't know how. But that would be a great question to ask, and has been asked, like, what's the worst part of the day? How do you handle the 3 kids? Those kinds of things. We let parents use their own words rather, and so it's a open format. But what will happen was there are a lot of questions about that in our assessment measures, and we'll pick items to start the conversation. So the feedback isn't a one-way street. It is a conversation that starts off. We'll give parents, look, you're in the red zone on this. Does this make sense? How do you see that? And parents will sometimes change it because it's gotten better or worse during that time. So it's this real dialogue going on. But yeah, we're trying to really get down to earth with it, or else it doesn't work. It's not going to touch home.
So I see this as being, if we're looking at early Head Start,
Yes.
I see this as really, if we're talking about early intervention, going even earlier, because the cases that we are dealing with in Prince George's County are same things they would probably be seeing in Baltimore City. And those issues are very complex. And so our families really could benefit. And I'm wondering, have you thought of going into the infant and toddler program with this?
Yes, well, Pamela will tell you about this, but coming up, but we're doing this as young as 6 months of age right now. Yeah, it's It's new for us. And I must say, Tom had doubts about that because a lot of our work was based on the kids walking and talking and causing problems, right? But of course, as folks can tell you, marrying others, the attachment piece is in the first year of life, and of course, that's what we're going to focus on. We don't have the curriculum that Mary does and things. Yes?
Are you addressing racial and cultural differences when there's like white interviewer, counselor, black or other race parents, and there might be cultural parenting differences? There might be, like I heard when she was talking about being afraid of being judged on the bus.
Yeah.
There might be racism that's coming up, and I'm wondering if that's being directly addressed.
Yes, it is. And, you know, I don't know if it's an issue in Baltimore, but in Pittsburgh, we have a dearth of African-American social workers and interventionists of our time. So we're in that position a lot of trying to go out of our way to recruit because a lot of our families, not all, about half of our families are African-American and half are white. I'll give you an example of this. When we were starting this work, we went to an area in Pittsburgh called Wilkinsburg, which is predominantly African-American. And we wanted to do a focus group. We said, hey, we're new on the block. We want to get your input on how you would feel about us coming in. And there were about 15 women, a couple of guys. I think one was a grandfather. I was running this focus group. And the immediate reaction, are there things we should be worried about? Or things you wouldn't take advantage, quote unquote, take advantage of this? And the answer was yes. We're very worried you're going to take our children away from us. I said, why would you be worried? Because sometimes we hit or threaten to hit our kids. And then I asked, why would you do that? And the answer was, there are no men around here, and they don't respect our voices. This is about 15 years ago, by the way. So, but the idea was that we need to have that ability, or else we're worried about our kids getting hurt on the street over time. And that, you know, so things like an issue like corporal punishment, which might be not be preferred, but in the repertoire, right? We work around that. We don't say, don't hit your kids. We say, how does that work for you? And use motivational interviewing around that. But if parents want to do that, we're not going to stop them from doing it over time. And we need to respect that all the time. Yes, please, sir.
Good morning, Father. Has there been any interaction or response with the legislatures, statewide and local municipalities, the faith-based community, reentry programs, sharing your data, and allowing them to come into the process to see how they can create some more ancillary services like assisted housing, in the school system?
Yeah. Boy, I wish I had you. You want to move to Pittsburgh?
I'm a Steelers fan.
I grew up a Baltimore Colts fan, so yeah, I wish. I mean, I am not. I don't go out of my way to speak to legislators, but we're trying to make, in my case, in Harrisburg, or our capital is, we're trying to make some hay there through different agencies over time and getting folks to notice us. So yes, we're making small steps, and I'm hoping our center can be an I think that's why Pitt did it, so I think it can be an advertisement for that. But I appreciate all the opportunities to do this, and I volunteer. I'll go anywhere to share our data. Our first 3 slides, I mean, that should scare the hell out of people, right? It really should, if you're a society, and it doesn't. I don't get it. I mean, and now we can do something about it too. So I share your concern. Yes.
Just a quick question. Is the maternal depression you refer to as actually postpartum depression?
It is not. It's a really good question. There were 2 researchers in my department, Sue Campbell and Jeff Cohn, who studied maternal depression at the same hospital recruiting, and most of that abated by about 6 months of age. And so by age 2, they followed the kids. It wasn't there unless I had depression before postpartum period. Then you see a lot of times that. But this is actually going up from year 1 to year 2. And after about age 3, it goes down a point every year in our samples, in our low-income samples. And you can see having the stress of a toddler raises about a point or 2 a year, and it will go down. That, by the way, is, I mean, if I've got any mark on all this, because parenting is there, is the maternal depression piece, predicting violent behavior at age 17, and it being more important at age 1 or 2 than it is your depression at age 10. That's something that's not intuitively making sense, but it says a lot about setting up that initial environment and how important it is. So,
So Denny, what have you built in to try to help address maternal depression?
it's really interesting. We get treatment effects on maternal depression, but we don't do CBT, right? And a lot of times it's having, so I mentioned it's just 3 or 4 sessions. I didn't mention there's about 15 phone calls in that year, right, over time. So I think it's having this person in the community that's out watching your back. So even though it's very short, I think that's why we get our effects on depression, frankly, because we're not doing CBT. We're clearly improving the quality of the relationship with that 2-year-old, which would make you a little less depressed overall. But I think more importantly, you have someone in the community that you know it's out there, and they're coming back next year. They're coming back next year. It's amazing. We have this woman from Oregon. We kept the camera on her. She's never had follow-up sessions, ever. And this is the age 9. Never had follow-up. And we left the camera on. The interventionist, Nancy, had to go get something. Camera was on, and she's talking to her husband. I'm so nervous right now. She's had 6 of these feedbacks. Every time she gets in the green, every time. But it means so much to her to receive this every year. It's very important what's going to happen. Of course, she did really well again, but she was all worried about it. So it is meaningful for her, and it really challenges the notion that families can't do this work themselves. I mean, that's the part, the lesson that this has all taught me, that we get treatment effects based on how many times you have a family checkup over the course of your child's years from 2 to 9. We do not get effects based on how many follow-up treatment sessions you have, which doesn't make any sense if you think we're teaching skills, very important parenting skills. It's all about getting that information and letting parents have control of doing whatever they want with it. And they make those changes, which challenges what I was taught. Yeah.
Hi, good morning. Do you consider any families that have children with additional or special needs and how that would impact your race?
Yeah, that's a great question. We do not take out families that have those needs, but that draws a lot of attention over time. So I know there's a program here about using Incredible Years with autism. We think it can be really helpful. My wife works in the ASD area too, so I'm always getting feedback about it, and she's always saying your program could help those families too, because it's about management, right? It's about how you respond to your child, and are you going to make it worse? It's Patterson's coercive cycle, but with an autistic or learning disabled child. So we don't rule out those kids at all, but we haven't studied them zooming in on a sample of kids that are like that per se. But we would not take a family like that out of our work at all.
One more.
Yes, please.
So back to the maternal depression.
Yeah.
Would you consider also, in addition to the appointments with you guys and sort of having that expectation, just the increased parenting efficacy, whether it's skill building?
Yes. Yes. I'm smiling only because the measure we use of efficacy has never produced any treatment effects. Like we can't find it. What we're focusing on now is mindfulness instead. Like we have a measure of that. We haven't yet looked at mindfulness as an outcome, but getting parents to kind of slow down and be more deliberate. And I think there's some parents, you might have seen this a little bit yesterday, a little defensiveness on the stand perhaps, that some parents who are kind of on guard might report higher levels of efficacy than they clearly have over time. And those measures have never worked. But in our model, that is exactly what we're trying to build, is confidence and skill building. I mean, that is it. We can't capture it with a self-report measure, but that is the core of what we try to do. And VIP does that too.
Thank you so much.